Welcome back. Today we're going to begin the first of our lectures on the endocrine system with the study of the pituitary and the adrenal glands. Now in these lectures we're going to study anatomy and physiology together each time so that we don't get too far away from the many glands we're going to look at. And I'd like to review just for a minute those general definitions that you heard before when we talked about some other endocrine organs, the pancreas for one. Basically, there are exocrine glands. Exo means out, crine means to secrete, and these are glands that secrete into ducts, like the digestive part of the pancreas or the salivary glands, and the substance goes out of the gland and into some lumen or other body cavity. What we're talking about here are the endocrine glands. These secrete within the body, and their secretions go directly into the spaces that surround the cells and eventually are picked up by the bloodstream. The endocrine system includes some organs that are wholly endocrine in function. For example, the pituitary gland, the thyroid gland, parathyroids, the adrenals, pineal gland. These have no other function at all. There are endocrine organs that have other functions as well as the endocrine function, such as the pancreas, because it also has digestive function, the liver we've studied, ovary, stomach, hypothalamus of the brain, small intestine, kidney, the testes, placenta, and these are compound glands or compound organs. And there are differences that we've reviewed before about how functions are controlled by the nervous system and how they're controlled by the endocrine system. And I think it's worth a quick review of that since it's been some time since we talked about it. Both systems coordinate functions of other body systems in general, and they're interlocked. The endocrine system releases the chemical messengers, which are called hormones. Hormone means to urge on, which then act upon other organs in different parts of the body. Now, some hormones promote or inhibit nerve impulses, while others, like epinephrine and norepinephrine, may be neurotransmitters themselves. These hormones act as hormones and not neurotransmitters. So when epinephrine is circulating in the blood, it's acting as a hormone. It'll directly stimulate an organ. When it's acting as a neurotransmitter, it has to go across the synapse and just stimulate the other side. But it has both functions. Hormones can take seconds to act, but they can also take minutes or hours to do their job, and their duration may be very long-lived. Hormones generally regulate growth, reproduction, metabolism, and they contrast with the nervous system, which is another signaling system. The nervous system acts by generation of nerve impulses, and they stimulate or inhibit an effector organ. They can stimulate the release or the inhibition of hormones themselves so that nerve impulses can go right to one of these endocrine glands and either inhibit it or stimulate it, or the nerve impulse can go right to an organ. And they travel fast. Those are measured in milliseconds, not seconds or minutes, which is what the endocrine system does. And they have very short-lived effects. It's also milliseconds. So it primarily causes muscle contractions or the secretion of fluids of certain glands, or it inhibits those. That's the electrical system. Now let's look at some of the organs we're going to study first. This is a view of the entire body and all the glands that we're going to mention. We start up here in the brain. There are endocrine functions in the hypothalamus. Hanging down below it is the pituitary gland and something in the back of the brain called the pineal gland, very small gland. In the neck, we have the thyroid gland, this big H-shaped organ, and behind it 4 little parathyroid glands, which we will talk about. In the chest is the thymus, which we'll get back to when we talk about immunology. And then down on top of the kidneys are the adrenal glands, also called suprarenal glands. There's our compound organ called the pancreas, and the stomach, ovaries, and testes also have secretions that we need to talk about and explore. The general properties of hormones, basically hormones number some 50 or more in the body, and each of them affects only a few cells, or a few kinds of cells. So we have to remember now we're pumping this out into the bloodstream. This is going to spread all these molecules to all parts of the body because the bloodstream goes everywhere in proportion to the blood flow that different organs get. What then accounts for the selectivity of these hormones only acting on a few kinds of cells? And the answer is what we call receptors. If you look at the next slide, there are on the surface of cells highly specific receptors. They are surface proteins or glycoproteins, which are sugar attached to proteins, and they have a very specific geometry. The molecules only allow for a very specific hormone to attach to that receptor cell. So if you look at this slide, you will see here's our endocrine cell that will drop some little particles, in this case they're represented as round molecules, into the circulatory system next to the cell. It will circulate and exit all parts of the body. But when it reaches these distant target cells, which are very far away, it will match up the shape of this receptor, literally the geometric shape, with the roundness of this hormone and signal the target cell to do something. Now, if you put a triangle in there, just by way of simple example, it wouldn't fit and it wouldn't signal the receptor. It has to be a perfect geometric fit. Furthermore, there's some regulation involved here. There's something called downregulation. When the target cell has, for example, up to 100,000 receptors for that hormone on a single cell, because these are just molecules, they're not macroscopic or microscopic, they're molecular. When you have so many, and you have other kinds of receptors too, so there may be millions of receptors of different kinds on every cell, if you get an excess of the hormone secreted over a period of time, the cell will decrease its number of receptors, and it'll decrease its sensitivity so it doesn't overstimulate. There's something called upregulation. If you have a very low number of hormone molecules circulating, the cells that are targeted can upregulate the number and sensitivity of its receptors so that you get just the right balance of the number of hormones you want for that situation. And this can be constantly changing. Now, locally acting hormones are something else. We just talked about the hormones that are most of the ones we're going to deal with here, and they act throughout the whole body. Of course, cells with no receptors just are going to get bumped into by a molecule and have no effect. There are something called locally acting hormones, and if we go back to this slide, down here we see something called a paracrine cell. We've just talked about endocrine, which secretes its molecule into the bloodstream. In this case, the hormone does not even enter the bloodstream. In this case, it just goes into the tissue fluid between the cells, what we call interstitial fluid, and this will go right across to the receptors of a nearby target cell. Paracrine means nearby. The endocrine suggests far away, and so here we're talking about microscopic, micron distances, not even centimeters. There's also a cell shown here called an autocrine cell. This cell is releasing a signal and it's sending it to itself. It's getting this signal on the outside of the body of the cell, and signaling a receptor on itself, which will then send the signal to the nucleus. This sounds kind of weird, but this is the kind we see very frequently associated with cancers. Cancers don't take orders from faraway organs very much, and they don't take orders from their neighbors. Most of our cells do take orders from their neighbors, and that way it prevents one cell escaping control. Cancer cells are autonomous, and they like autocrine signaling. And if the cancer cell wants to grow, it's going to signal itself to grow and ignore everybody else. So that's why I wanted to mention those here, because it's another type of hormone signaling that needs to be remembered, because it will come up in other areas that we talk about later on. So let's move to the first of our glands. First one is the pituitary gland and the hypothalamus. Here's the brain, shown in diagram. And down here, blown up from this tiny area just below the hypothalamus, is the pituitary. And it looks like this. It sits in a bone at the base of the skull, which you've seen before, and there are 4 little horns. There's 2 here and 2 here, front and back, right and left, and it's called the sella turcica, or the Turkish sow. That's what it looks like. The gland sits down in that. The pituitary is also called the hypophysis, and it was thought at one time that this was the master gland that controlled everything, all the other endocrine glands. Now, I want you to remember, when you look here back at the slide again, remember the optic chiasm sitting right next to the and in front of the pituitary gland. This is where the nerve fibers cross over from the optic nerve. And I told you this was going to explain how David slew Goliath, and we're finally going to get there later today. So the pituitary sits there right behind the optic chiasm in the sella turcica. But the hypothalamus above it is what actually controls the pituitary gland and integrates messages from many parts of the body telling the the pituitary what to do. And together, they basically regulate all the processes that have to do with stress, with fight, flight, body temperature, thirst, hunger, sexual activity, survival in general. So this is a very, very basic function. Between the hypothalamus and the pituitary, they secrete about 16 different hormones. Now, embryologically, the pituitary is divided into 2 distinct parts, and functionally 2 distinct parts. It's what we call the anterior and posterior pituitary, and they don't talk to each other. The anterior pituitary is called the adenohypophysis. Hypophysis is that other word for pituitary, and it comprises about 75% of the gland. As you can see here, it functions. Here's the anterior part, much bigger than the posterior part. It connects with the hypothalamus through a portal capillary blood system. We've already talked about the portal capillary system being a very good way to conserve molecules because you're going venous to venous capillaries. You're not having to circulate whatever you want through the whole body. So here what it does, it allows this small gland to make only a few molecules so that the brain can communicate a very short distance, very small number of molecules, and it doesn't have to get lost in the larger economy of the body. The anterior pituitary evolved anatomically up from the floor of the mouth. So without showing it to you in a slide, basically it came up through this bone and evolved here. And the neurohypophysis, or the posterior pituitary, came down from the brain, and they lie against each other, but they don't have connections. Now, this is why it's called the neurohypophysis, by the way, because of just where it originated. Remember I told you that sometimes when we want to destroy the pituitary, we would come up from the mouth? It's the perfect place. Right above the roof of the mouth, where it arose, is where it sits. Very short to get there. Now, the other hormones that come down from the brain, from the hypothalamus, to get to the pituitary are called releasing hormones. And what they do is circulate a signal that tells the pituitary to release something that's going to either inhibit or stimulate something somewhere else in the body. So the 7 releasing hormones are secreted by the hypothalamus, and they are responsible for the release of the specific hormone in the pituitary, and they have kind of funny names. There is, for example, the hormone that releases the growth hormone is growth hormone releasing growth hormone. And there is a negative one, which would be the growth hormone inhibiting hormone. And so you basically have to just list these in your mind and remember to go where to look them up when you're done, because you're not going to remember them, especially after one lecture. The anterior pituitary hormones are also controlled by a negative feedback method, not only from the brain, but from the target organ. So when the target organ responds to one of these hormones, its hormone itself, circulating in the blood, will go back and turn off the anterior pituitary. It's a negative feedback loop. For example, if thyroid stimulating hormone is released from the brain or from the anterior pituitary near the brain, it'll circulate down to the thyroid in the neck. The thyroid will then be told to release some of its hormone, thyroid hormone, into the blood. And it will go to the organs that it regulates, which is generally an upregulation. Some of that hormone is going to circulate back to the brain and say, here's how much hormone is in the blood now, I can turn off the stimulation. And it's this negative loop feedback that controls it in a very fine balance. I'm going to go through with you the basic anterior pituitary hormones and name them, tell you fundamentally what they do, and then we'll generally come back to them as we look at other parts of the body. So refer to your notes. Don't try to memorize this. Just try to think of what the names are and what they're doing. The first one is called thyroid stimulating hormone, or TSH. It stimulates the thyroid to release thyroid hormones, and they tend to upregulate metabolism. I'll talk to you more about malfunctions, and I think that will make these stick in your mind a lot better. Follicle stimulating hormone, called FSH, and luteinizing hormone, LH, together stimulate the release of estrogen and progesterone, which causes the maturation of the ova in the female egg and sperm cells in the male, as well as testosterone. So these two similar chemicals, same in male and female, will go to different organs in each of those two sexes and do something else. But basically, they are reproductive hormones that get the egg ready, or I should say the ovum, the ovary ready to secrete an ovum, while same time getting the production of the male sperm ready for the same job. Prolactin stimulates the production of milk by the breasts during pregnancy. And in fact, this is a small enough molecule that it goes across the blood placental barrier. And babies can get some of this prolactin. And there's something called witch's milk. Every now and then a newborn baby will secrete milk from its own nipple, as well as having the mother secrete milk from her nipple. Nothing pathologic. As soon as the baby's born, eventually those levels will go down because there's no placental connection. And it, over the centuries of the old days, has been called witch's milk. Then there's a hormone of the brain that's probably, of the anterior pituitary, which is probably better known to you, called ACTH. This is one that we have used in synthetic forms and natural forms in medicine for a long time. It's adrenocorticotrophic hormone. What does that mean? Adrenocortico means the adrenal cortex. Trophic means it stimulates. So this is the hormone that comes down from the anterior pituitary. It stimulates the cortex, or the outer layer of the adrenals, to release certain other hormones, which I'm going to get into detail later in this lecture. There is a melanocyte-stimulating hormone, which causes increased skin pigmentation. That comes from that portion under the brain as well. And finally, human growth hormone, or somatotropin, causes body growth. It regulates the metabolic processes in the body. And high HGH, human growth hormone, increases the growth of the skeleton during your growing years in the child, and it maintains muscle mass and skeletal size in the adult. Very, very important function all through life. Now, I think it's useful at this point to go back now and look at the pathology, what happens to people who have abnormalities here, now that you've got this confusing list of hormones with new names, presumably. But if we put them together with a disease that you can picture, then you might be able to retain them more easily. Let's look first at pituitary dwarfism. Remember, all these hormones can hypersecrete or they can hyposecrete. They can overproduce, they can underproduce, and they produce different diseases. Pituitary dwarfism, if you have a low level of human growth hormone during the growing years, this is the time when the growth plates on the bones are open and it's possible for the bones to still grow. This causes growth plate closure before normal size is achieved. So in pituitary dwarfism, the low levels actually makes the plates close. They don't keep them open, and the child stops growing. Many of their organs are actually small. They have a childlike stature. And we have produced a synthetic human growth hormone in the past decades using recombinant DNA in bacteria, so we had plenty of sources. There's very few molecules of human growth hormone available because there's not that much in your blood. If we were to need a supply of this, we would have to take lots of blood or tissue from people and concentrate it. It'd be vastly expensive, dangerous, because we might transmit diseases. But when we got into the recombinant DNA technology of the modern era, we could produce as much of this as we needed, and we have plentiful resources, and when we make this diagnosis, we can give these children, before their growth plate closes, human growth hormone and get them to near normal or normal size if it's done in time. Has its downside. I think one of the risks we're always thinking about is certainly that, again, you can't fool Mother Nature. Cancers all need human growth hormone for their growth. So we all begin to worry about what is going to happen to these children later on in life. We think this is still safe to use under very controlled circumstances, but not the kind of thing you want to fool around with a normally sized person to make them extra big. This is when you get into real trouble. The opposite of this, or not the opposite, but actually the opposite syndrome for both children and adults is called pituitary giantism. If you have hypersecretion of the human growth hormone during a time when you're still growing, again, like the other child, you can get very long bones, tall stature, but the proportions are quite normal. This patient might be 7 feet tall, but they're slender, they're normally proportioned like any other adult, just bigger. But there's another disease called acromegaly. If the tumor functions, for example, if you have a functioning pituitary tumor that's secreting this hormone, which happens, in an already normal adult, his or her bones can't grow anymore. The growth plates are closed. It's not possible. So the bones thicken. Everything thickens in this patient. The bones get heavy and thick. The skin gets thick. The tongue gets bigger and thicker. Muscles get bigger. Eyelids, nose, all the features of someone who has what is called acromegaly. Now, let me take a little diversion and bring you back to David and Goliath. Remember the visual fields? We looked at these long ago. If you take the lateral visual fields, the peripheral fields, which bring in light and strike the nasal or medial side of the retina, that fiber goes through here and crosses the optic chiasm and ends up on the inside, on both sides. Suppose I took something right here and started expanding it, like a pituitary tumor. If I had a patient with a pituitary tumor that developed in adulthood, that patient would become thick, acromegalic giant. It's called adult pituitary giantism. That patient might also have, if the tumor got big enough before it was taken care of, pressure on these fibers which come from the peripheral fields. So the doctors in their detective work decided, what happened to Goliath? It's very likely that Goliath, unless you're looking for some other cause, the most common cause for him to be built the way he was described was to be what we call an acromegalic giant, and the most common cause of that is a pituitary adenoma or growth hormone secreting pituitary tumor. He would be a big, strong man, much bigger than everybody around him, and he would have tunnel vision. He would be blind in his peripheral vision. So David could come out there with his rock and sling, walk up to the side of Goliath, never be seen, and nailed Goliath in the temple with his rock, never having a chance to turn on David. And that rock would happen to hit from the side, the thinnest part of the skull, the place where you're most likely to do damage, which would be the temporal bone. So we've decided, at least the doctors who looked and said that must have been the answer for David and Goliath. He was a pituitary giant, and David made use of that in his battle. The posterior pituitary gland, the neurohypophysis, which is here, and it actually starts up on top and in front and slides down the back and sits right there. And as I said, they do not talk to each other. Posterior pituitary gland is basically derived from the downgrowth of the brain. It does not synthesize hormones. It stores and secretes two of them. So those hormones come from the hypothalamus into the neurohypophysis, and they're in little packets. They're made in the brain and transported in literally inside little membranes in the pituitary and its posterior side. Very important one of those is oxytocin, also called pitocin, because it comes from the pituitary. And oxytocin means rapid childbirth. This is the hormone that enhances the strength of uterine contractions, stimulates the ejection of milk after delivery. It also probably fosters maternal instincts emotionally, and it's probably responsible for the sexual pleasure after and during intercourse. It is synthesized in the middle part of the last century by a chemist named Claude Duvigneau, so it became readily available. And it's what we use when we want to get someone to go into a stronger labor. Women who may have broken their membranes and have not started forcible contractions, or women who are contracting and not dilating, which we'll talk about later, and basically need some help in pushing the baby out, are usually given Pitocin, or what's known as a pit drip, at a very specific rate to hormonally whip the uterus and get it to expel the baby in good time. Very, very major advance in chemistry. Whether or not it's good or bad for any individual patient takes a lot of judgment and has its upside and downside, just as any other drug does, powerful drug. But it certainly has been used a great deal, very, very important part of gynecologic care and obstetric care at the moment. There's another one in the neurohypophysis called antidiuretic hormone, also called vasopressin, because it raises blood pressure. This hormone works by acting on the kidney, on the transport system of the kidney, which we'll get to later, and it decreases urine production. It makes the kidney keep water instead of getting rid of it at the rate the kidney would have gotten rid of. So its effect is basically to get your tank, your vascular tank, over full, because it's coming back into the blood. It's coming to the kidney in the blood instead of going out in the urine by filtration or other methods. It's staying in the blood more than it's supposed to when it works. So it raises blood pressure. And alcohol inhibits ADH secretion, antidiuretic hormone secretion, by a direct action on the neurohypophysis. And that is why after a drinking binge, people usually produce a lot of urine. They also are drinking more fluids in the case of things like beer, but any alcohol, even small amounts, will cause this effect. And much of the headache that people get with hangovers is dehydration. Their vessels are too lax, and they get headaches from the dehydration of that binge. And so that prophylactic rehydration by just drinking water after drinking helps these people avoid the headache as part of their hangover. We're going to talk more about the vasopressin a little bit later when we come to the adrenal glands, which is right now. So that's the pituitary. Let me just show you one more picture because it's a nice picture. Here is the hypothalamus. Here's the primary plexus wrapping around the neck of the hypothalamus, and this one going back down to this portal system that's wrapping it up here. And then these are going to return to the anterior hypophysis. So we've got this economy of the portal system. And here is the completely separate blood supply of the posterior pituitary, which has come down from the brain. Of course, the optic chiasm would have been here, and Goliath's pituitary would have caused pressure on the right and left sides. Let's go now to the adrenal glands. The adrenal glands have their name because they're sitting on top of the kidneys. This is way, way in the back of the abdomen. Here's that celiac trunk you now are familiar with. It comes in from the aorta. Here's the SMA, so you know where it is, in the upper portion of the abdomen. And coming right off the aorta is a vessel, one vessel on each side to each kidney. We don't have good collateral circulation here, but we have two kidneys. The adrenals are literally that. Renal refers to kidney. There's the renal vein, the renal artery. And adrenal means they're sitting on top, added to the renal organ. So that's why they're called the adrenals. The position is way, way in the back of the body. They're retroperitoneal. They're about 2 inches long, very, very small. And they receive a copious blood supply. These are too important to be trusted to a blood supply that may be cut off. If you look here, there's a right and left inferior suprarenal artery, one on each side, going straight to the adrenal, or the suprarenal gland, it's also called. There's the right middle suprarenal artery coming off here, and the left. And then finally, there's a big artery called the inferior phrenic that comes off the aorta high and goes straight up to the diaphragm to supply this huge, huge muscle. And it sends branches to the adrenal. So it gets branches from 3 different arteries on each side. Consider that just very important. Now, the anatomy of staying with this slide, the anatomy here is this adrenal has been cut in half right through its center. And it has a capsule on the outside, which is very, very thin and filmy. It has a cortex, which is always the outside, and it has a medulla. And these have evolved separately. Their origin is what we call the neuroendocrine system. Part of this has evolved from the nervous system, which is the adrenal medulla. We talk about adrenal medullary hormones, and the outer cortex is not, but they've come together in one organ. Now, if you look at this, the cortex produces basically 3 separate hormones in actually 3 separate zones. And well, I'm not going to go to this slide yet. This we'll have a review of this at the end. The mineralocorticoids, the minerals are dissolved electrolytes in your blood and other chemicals. The mineralocorticoid, which is primarily aldosterone, is 96% of this group. It controls water and electrolyte balance, sodium and potassium, 2 of our very most important ions that are in the blood. It regulates homeostasis, and it acts upon the kidneys. Now, there are what are called adrenal adenomas. So you can get a benign growth of tissue in the adrenal cortex that can secrete. It's an active secreting benign growth, and you get hyperaldosteronism. This causes patients' blood pressure to go up, again by regulation of water. And it's believed by some people, especially a Dr. Kahn, who discovered this syndrome, that maybe as many as 25% of all people in America with high blood pressure may have a small one of these tumors. They tend not to grow fast. They tend not to be malignant, but they can produce high blood pressure. Treatment of this kind, of course, is removal of that adrenal tumor. Then there's another group of hormones, and they're called glucocorticoids. Cortisol is one of them. It's also called hydrocortisone in its most common name, and that's about 95% of the total glucocorticoids. And this drug depresses, number one, depresses the immune system. That's why it's used to fight inflammation. When you give someone hydrocortisone, it's usually in fighting an immune disease, suppressing an overactive immune system. For a simplest example would be an allergy. If you were allergic to something on your skin and got a rash, the doctor would give you hydrocortisone cream to put on it. And we can also use it inside systemically. It promotes protein catabolism, meaning the breakdown of protein. It promotes the breakdown of triglycerides into fatty acid. It also promotes the resistance to stress, meaning higher, for example, higher blood pressure. It has anti-inflammatory effects, which is the same as I mentioned about its allergy. And it retards allergic reactions, but at the same time, it's going to slow down wound repair. So if you give someone hydrocortisone systemically because of an allergic reaction, an inflammatory reaction, and that patient's undergone surgery, you might substantially reduce their ability to heal their wounds. And when you have inflammation and a wound, you've got a problem. If you've got something that's inflamed, you'd like to reduce the inflammation, but there's something that needs healing, there's going to be cross purposes because you'll get rid of the inflammation, but the wound may not heal. It also promotes what's called gluconeogenesis, the production of new glucose from non-glucose sources. So you could take amino acids and other things that aren't sugar and promote that genesis of sugar when you need it. So going again to diseases of the adrenal cortex. Addison's disease, named a long time ago for Dr. Addison, centuries ago, results from adrenal cortical insufficiency. So here we are back at this slide. This part, the outer part of the adrenal, is insufficient, producing not enough of the corticosteroids. This produces something that looks like down regulation. The patients are lethargic. Their blood pressure tends to be low. They have weight loss. They lose their appetite. Their blood sugars are low. And we can treat them giving them the steroid hormone, cortisone, in various forms. There's lots of synthetic and natural forms we can use for different reasons. Probably the most famous person that we all remember is John Kennedy. Had Addison's disease. He was hypoadrenal. And that accounted for lots of odd things we saw during his presidency. For example, if you go back and look at pictures of Kennedy during specific times, during the Bay of Pigs, during the Cuba Missile Crisis, other times of huge stress, his doctors, who were ever in attendance, had to give him increased levels of cortisone to meet the challenge of that stress, or otherwise he would collapse. And he also had some other illnesses, but they were always there titrating or trying to figure out the best level. During great stress, he had to have great levels of cortisone. Cortisone causes deep skin pigmentation and some retention of fluid, which gave Jack a very nice tan and a puffy face. He actually looked his best when things were worse. He looked like he just got back from Palm Beach. He really just got back from New York Hospital where they were busy titrating his drugs. So he was actually given a dose which made him look like the next kind of patient we're going to talk about. That's the patients with Cushing's syndrome. These patients have an excess production of adrenal cortical function. And this results in a combination of spindly arms and legs, a big fat puffy face, probably worse than Jack Kennedy's ever was, a deposition of fat on the back, which is called a buffalo hump. They have flushed skin, they have high blood pressure, their bones are demineralized because cortisone is very bad for your bones, and they have a decreased resistance to infection. So this part of the adrenal on the slide is producing, again, a different cell is producing too much of the drug, cortisone. Now, it may be from a tumor, but it may be that the whole adrenal gland is malfunctioning at once. Also in the adrenal cortex are androgens, masculinizing hormones. They're in very, very small, insignificant amounts in the adult male. Most of that is made in the testes. In females, androgen accounts for sexual drive. It's converted into female hormones as well after menopause, but it accounts for the levels of things like testosterone, which in the right dose in the female increases sexuality. Now, we talked about breast cancer some time ago. And today this isn't so much of an issue, but it kind of brings things together. The female hormones, estrogen, stimulates the growth of most breast cancers. So before the days of anti-estrogen drugs like tamoxifen, we removed the ovaries, the main source. The adrenal then took over. It wanted those estrogens, and it made more estrogens out of the adrenals, so we could go either take out the adrenal, which was a very big deal, or we could destroy the pituitary. And some of the patients with breast cancer actually underwent the operation through the roof of the mouth into their pituitary and destroyed that, so the ACTH, the adrenal corticotrophic hormone, wouldn't come down to the adrenals and stimulate it to make its products, including estrogen. They had to then have replacement therapy for everything but their estrogens. We would give them the other chemicals that they needed, like cortisol, but not the estrogen drugs, to replace it. You made these patients very, very sick. They were very brittle. It was a difficult thing, and fortunately today we don't have to do that. We just have anti-estrogen drugs, which are very specific and require a pill a day. Let's move on to the adrenal medulla, the neuro part of the neuroendocrine system. That's the middle. This one produces hormones that are produced in something called chromaffin cells. They are innervated by the sympathetic division of the autonomic nervous system, so that the adrenal gland itself has innervation. It has connections from the central nervous system. It's autonomic, as we know. When you stimulate it, you basically get two hormones, epinephrine, which is 80%, and norepinephrine, the neurotranslator we talked about, also called adrenaline and noradrenaline. So in the neurotransmitter portion, almost all your chemical is noradrenaline. Coming out of the adrenal, most of it is adrenaline. Slight differences in that radical. These are called collectively catecholamines, a word you'll hear a lot, so I just want you to hear it now. But basically, those are the two together. They represent, in this area, the postganglionic fibers of the autonomic nervous system on the sympathetic side. This is kind of an expansion and development of what would be releasing norepinephrine from the nervous system. Okay, so, and the chromaffin cells, which are directly innervated by the fibers of the autonomic nervous system, they respond very quickly to any stimulation that needs to get the emergency system upregulated. It functions, the gland functions as if it were a postganglionic fiber. So where you have, for example, the nerves to the heart, you would have your preganglionic sympathetic fiber come out, fire in the ganglion, and fire to the heart. It will do that during stress, during fight and flight. At the same time, it's going to send an impulse down to the adrenal gland, which is going to squirt a whole lot more into the system for a longer, more sustained reaction. Remember, the one impulse that came down from the sympathetic trunk is only going to give us one shot across the nerves, let's say, to the muscles of the heart and everywhere else it's going. And then you're going to have to fire again and again and again. But the one or two shots to the adrenal gland, it's going to really squirt out a lot of that chemical, and those hormones are going to last longer and be more widespread. So it's basically a backup. It's something in a very important system that is survival dependent, and it's going to make the whole system stay upregulated in a life and death situation. Unlike the adrenocortical hormones, you don't need medullary hormones, the hormones from the medulla, in a quiet life. So if a person didn't have his adrenal medulla, as long as we didn't stress them, they'd probably be okay. Now, there is a tumor that occurs here, an adrenal medullary tumor called pheochromocytoma. Forget that name, but we call it pheo, those who are familiar terms with a pheochromocytoma. It's a secreting tumor of the catecholamines. And these patients get what is called paroxysmal hypertension. They get sudden outpouring of the catecholamines, norepinephrine and epinephrine, and out of nowhere, their blood pressure goes up, their heart races, their face flushes, they get panic reactions, and it's paroxysmal. It comes in bursts. It's a surgical disease. You remove these pheos. They're not very common. Not a lot of people have experience with them, so it's good to go to a center that knows about this. And the most important person is this anesthesiologist. He's got to prevent malignant hypertension, a sudden onrushing of these, particularly when the surgeon picks it up and may squeeze some out so that the patient doesn't actually blow out their brain or their cerebral vessels with the increased blood pressure or injure the heart. And they do this chemically with drugs by blocking it. Meanwhile, the surgeon on his or her side is very, very careful not to handle this tumor too much until they've got the whole blood supply controlled. Very challenging, fortunately very rare. That's your introduction to both the pituitary gland and the adrenal gland systems. And next time we'll move on to more of the endocrine system.